So, could you give me a brief history of your experience in working with childhood trauma and your therapeutic modality?
Okay. So I came into recovery in 2003. I started working in the voluntary sector for Westminster Drug Project in 2005. And I started as a volunteer, then a practitioner, then a senior practitioner. By 2010, I was managing a team there delivering a structured day program for people on DRRs and ATRs, so court ordered rehabilitation treatment. In that process, obviously, I was working with a lot of frontline drug and alcohol addicts, and cross addicted addicts, and the common thing that was very clear was underlying trauma. Everybody I was working with, there wasn't a single client at that frontline service, which eventually became the entire Northwest Minster drug and alcohol service. So over 3,000 clients at any one time, many opiate prescribed. They all had underlying trauma. So as we were working from a harm reduction model on things like methadone scripting, relapse prevention, controlled drinking, or that kind of approach, what I found was that people's resistance to sort of even looking at what was underneath their addiction, it just wasn't there, and it wasn't part of the agenda. The agenda was literally to keep them safe and not to consider what was going on underneath. That's very much in contradiction to my own recovery. So I came through a 12-step rehab. I am a member of Narcotics Anonymous. I work an abstinent program. I have been in therapy ever since, well, even before I got clean and sober. And my understanding of my own recovery is that my addiction is a coping mechanism to deal with my childhood trauma. And that's, there's lots of different elements to the childhood trauma that I experienced, but smoking cigarettes and drinking alcohol were a reaction to the difficulty with the emotions that came or were associated to my trauma. So I had this understanding. And then what happened professionally was that I found it quite difficult working in harm reduction. I started to veer towards the private sector and the more 12-step focused treatment centres. And then when I got to 2012, I was working for Charter Harley Street, and I was doing some charity work for different services. And I started training as a psychotherapist, qualified in 2014, and then set up my private practice, and then went on in 2016 to start working for Steps to Recovery, which is 100% 12-step recovery treatment center, which is a charity. And it was there really that I consolidated, or that last bit of the journey where I consolidated my understanding of trauma, addiction and recovery and psychotherapy with, the contradictions that I found in the harm reduction voluntary stroke statutory sector. And I started to really work with people's trauma in Steps to Recovery, where people are abstinent. It started a bit in Charter Harley Street, but a lot of those people had done the primary work, and I was working in the aftercare. So a lot of people, it was less about their trauma and more about day-to-day recovery. But at Steps to Recovery, really started working with people's trauma. And then obviously in my private practice, I don't just work with addicts and alcoholics. I work with people with all different issues that they bring to psychotherapy. My modality, I would say, is a cross between psychodynamic, 12-step, and person-centered.
Okay.
But I bring in bits of CBT and bits of MI when it's necessary. But also I come from a Buddhist family, and I use a lot of that philosophy in the way that I work. So a lot of mindfulness and meditation, a lot of existential conceptual aspects I bring in from my understanding of Buddhism and how that relates to life. So there's lots of different things that I bring into it. But primarily I would say I work from a very psychodynamic perspective, in terms of I look a lot at people's attachment, and I look a lot at people's paternal maternal dynamics, however that may exist. because obviously there's a lot of variation in that, and some people have lost parents or have had abusive parents or didn't know their parents. So, but I think those early attachment patterns of relating are vital to effective psychotherapeutic work of any kind. So I don't think, for me, I can't really work on just the here and now without really having an understanding of what it is that happened to that person in the first 10, 15, 20 years of their life.
Mm, mm, mm. Thank you. Thank you for that, Chula. And I really agree with you in terms of working psychodynamically with clients affected by childhood trauma, and not just by staying in the here and now, because it's important. But thank you for that. And okay, so the next question is, and you kind of touched on this, what are the most common themes you encounter when working with this client group?
When you say this client group, do you mean the trauma client group or the addiction?
Childhood trauma.
Childhood trauma.
Yeah.
Well, most of the issues seem to manifest in relational aspects. So it's either relationships with partners, friends, family, or work relationships. That's how they manifest in the here and now, the childhood trauma. So what I find myself often doing is working backwards. So someone will come to me and they will say, for example, I keep getting really paranoid at work that other people are talking about me and that everyone's in the kitchen talking about me, and I feel really separate and insecure and paranoid around this. And we'll look at that, but then we'll kind of move back. Okay, so when did you start? When can you first remember having feelings like that? And then that may go back to school, it may go back to the environment within the family, but inevitably those kind of relational difficulties that people face in adult life, I find, lead back to the primary caregiver relationships and the experience in those first 5 to 10 years, really. So we'll start looking at that. We'll look at parallels. We'll look at links. We'll explore really the individual's understanding of their childhood experience and the childhood trauma that they would identify, and then would have a look at how that's playing out in the here and now. And for me, it's about bringing the unconscious into conscious awareness and sort of almost being able to separate that. So rather than being, someone once asked me what's my definition of recovery, and my personal definition was to be the person that I have always wanted to be and not the person that my trauma dictates. So that's part of the way I work. Sort of, I feel that a lot of people, their unconscious material informs their personality, their relationships, and their life trajectory. And some of that they're completely unaware of. So therapy is about bringing that into someone's awareness so they can say, okay, well, I've got a problem in this area, and it's actually to do with a lot of the unconscious material that I'm holding. And that unconscious material is associated with trauma in the broadest sense.
Right. Thank you. That's very helpful. Have you ever personally experienced any relational challenges when working with this client group?
In terms of therapist to client relational challenges? Oh, yeah, definitely. There's a lot of transference. There's a lot of counter-transference when you're working with trauma. Especially, for example, if I'm working with someone who had an abusive father, then often there'll be transference in that. And I don't generally tend to bring that in unless it appears. So if it shows itself, then I will take note of it and I will encourage the client to become aware of it and bring it into the session, but only really if it's quite obviously there or they bring it in. So I know that it might be a possibility, but I don't make the assumption that it will always manifest. In the same way with counter-transference, when I go to my clinical supervision, I look to see if there's any counter-transference and whether I'm acting from a place of counter-transference. And I think that's vital to maintaining a solid relationship. The other thing I would say is boundaries. So many people with severe trauma, especially childhood sexual abuse, where there's been boundary violations as part of the trauma, then those clients tend to push the boundaries of the therapeutic relationship,
Mm,
and push the boundaries of the therapy. And that can manifest in several different ways. Sometimes it's practical, it's about money or time or attendance.
mhm,
Sometimes it's about asking personal questions. Sometimes it's about refusing to give to the session or give to the therapy. So
mm,
the
mm,
boundaries can be all over the place with somebody who's experienced severe boundary violations as part of their childhood trauma. So again, it's about bringing that to the awareness and actually talking about it, really making it live, making it real. I think it's my job basically not to ignore that when I observe it, not to ignore it, and maybe even say, oh, I've noticed that you often forget to pay, and after a few days, I have to remind you, or I have to remind you at the next session.
mm,
I was wondering what that was about. So I
mm,
just bring it in and see where the person wants to go with it. In
mm,
my head, I may have made some conclusions or assessment that it's linked to childhood boundary violations,
mm,
but
mhm.
I won't suggest that. I'll just bring it to the client and see where they're able to connect to it, and
Right.
then go from there. Yeah. So I try not to be, in that way, I work in quite a person-centered way. I
Mhm.
try not to be suggestive or directive. Um, but then at the same time, I'm not scared to answer a question. And if somebody says, what do you think I should do? I won't tell them what I think they should do, but I will give them separate options. So
Mm,
I would say, oh, well, some people might look at it like this, and some people might look at it like this, and some people might choose to do this. You know,
mm,
what do you feel about those different options?
mm,
So
mm.
I reflect it back in that way rather than being directive.
Right, right, right.
Yeah.
Thank you for that. Okay. In your experience, how do you feel the depth of the therapeutic relationship impacts on the healing for your clients who have experienced childhood trauma?
I think it's really important. I think trust is really important. The therapeutic alliance and the level of trust in the therapeutic alliance
Mm,
is vital to a client's ability to feel safe and secure enough to um, be open and honest in terms of the therapy and what they bring, and how much they talk about their true experience of the childhood trauma. And I think some clients, they're not fully aware, they're not fully conscious of everything, so it takes some time for that to come about. Others will be conscious, but they'll deliberately hold back. Others
mm,
will be unconsciously holding back. So there's a lot of different ways in which clients can resist building that trust.
mm,
But all we can do as therapists, or all I hope to do, is to just provide a safe and secure place and support people to feel held in the therapeutic space. And what I find is eventually, I would say 99% of the people I work with, if they stay in therapy with me, we always get to the crux of the matter.
right.
That I've built good technique, I believe, and good ability over the years, having worked with many people. I've developed the ability to hold that space and support people to feel comfortable enough and secure enough to start to trust.
Mm,
um, I've had a few where they haven't been able to do that, or I haven't been able to give them that.
mm,
I would say the majority, it happens eventually. It just happens in different ways at different speeds.
right, right.
Yeah.
Okay. Yeah. Okay. Um, did you ever experience any hesitancy or challenges in bringing aspects of your work to supervision?
Um, I don't think I have, because first of all, I had very good clinical supervisors.
Mm, mm,
Um, I I'm very keen to analyze my work and to look at where I may be doing things that aren't helpful to the client. So I've always wanted to be the best therapist I can possibly be, and do things to the best of my abilities. So I've always used clinical supervision quite consciously and quite proactively. So I don't think I've ever been hesitant in terms of avoidant, but there have been lots of things where I thought, okay, my clinical supervisors are going to be happy about this, or they're going to tell me off about my boundaries, or they're going to think I'm a terrible therapist. I do have those feelings, but I don't allow those feelings to stop me from bringing, because actually those feelings are an indicator that I do need to bring that thing to clinical supervision. So, like with recovery, I've learned to go against my avoidant tendencies. So when I recognize a hesitancy or resistance, I try my best not to give into it. I try my best to go against it and expose myself to my clinical supervisor, because that's how I grow. That's how I learn. And I've been very fortunate enough to, have clinical supervisors who I've felt safe to do that with, and who I will literally, expose my shortcomings or my fears. Or there's been times when I've done things wrong, and I've known I've done things wrong, and I could have not taken that to clinical supervision, but I choose to take it because I don't want to do it again, and I want to understand what it is I did and why.
Thank you for your honesty with that question. Okay, thinking about the clients you work with in this group, what do you feel has impacted favorably or not so favorably on outcomes during the course of your therapeutic relationship?
I think that falls into two categories. So a lot of the work I do is in addiction. I've come from that background, and that is my speciality. And I would say when I'm working with that particular cohort, the main sort of the strongest influencing factor is the client's ability to manage their addiction. So when clients are in active addiction, but they're very reluctant to experiment with a period of abstinence, or experiment with going to support groups or fellowship of any kind, which I strongly encourage with people who are addicts and alcoholics. If when they refuse to do that, and they continue to stay in active addiction, that I find is very challenging, and that, to me, in my experience, slows down their therapeutic process. And what I've recently had was, I had 3 people recently who were being very resistant for a year or two, but then consequences happened because of their drinking and using. And I actually said to them, okay, look, we've done it your way, and it's obviously not working. The evidence shows us it's not working. I'm going to ask you now to do it my way. And then what I get those people to do is 90 days of abstinence, go to 2 meetings a week of their choice, and to come and talk to me in therapy. And I've got a resource pack that I ask them to start working through, things to read and watch and stuff like that. And then we explore that period of abstinence and see what happens, and allow it to come to its natural conclusion. With those specific people, they generally have a light bulb moment and realize, oh my gosh, this is what I need to do. And they're like, these meetings are great. This is amazing. I'm feeling something I've never felt before. And then actually more things come out in the therapeutic work, and they start talking about more trauma that perhaps had lay hidden. So with the addict cohort, I think abstinence and recovery is really important if we want the psychotherapy to be as effective as it can possibly be. With the non-addict cohort, so I've had people who have been problematic drinkers or users, or people with depression or bereavement or relationship issues or anxiety and stress, who I would say aren't addicts. With those people, I think what's been the most hindering has been, I suppose, their ability to withstand the pain of the trauma when it starts to come up.
Right.
Yeah. So when it's been really, there's many people, you start working and you see things coming up, and you see the pain coming up, and they push it down.
Mm.
And obviously at those times, I don't push further. I allow the client their process for things to come up, and I allow that organic flow to happen. And different people, again, it's different rates of progress with that. So some people can withstand more of that childhood trauma pain, and therefore you can do a bit more work on it and then close them down before the end of the session. And other people, their reflexes are so quick, you know, their coping mechanism, they shut the pain down so quickly that it takes longer for them to get to a place where they can actually allow themselves to be with the pain. So I just hold them through that process, but I would say that definitely determines how quickly or slowly people get better.
Right.
Yeah, because when people are able to sit with that pain, they start to heal. You know, and then you see people start to shift and change and get better, and get stronger, really, and make the changes that perhaps they've wanted to make but weren't able to before therapy.
That was really helpful, Chula.
Cool.
Okay. Do you feel your therapeutic orientation has a major factor on how you work with this client group?
I don't believe that somebody in recovery is necessarily going to be a good psychotherapist or an addiction therapist. I don't think it's a prerequisite. I think there's plenty of people without an addiction history who are great psychotherapists and great addiction specialists. So I don't look at it in that sort of 1 + 1 = 2. However, what I would say is that I do believe that my own experience as someone with childhood trauma, addiction, and recovery, I think my experience informs the way in which I work. And I do think that my experience, when I first worked the 12 steps, I thought they were a very rudimentary therapeutic tool. But now that I've been around them a few times and I've done all the training that I've done, I've worked with many people, and you know, I keep doing the CPD, and I've learned a lot from a clinical perspective. And I've picked apart the 12-step program, you know, and analyzed it from a clinical point of view. I now realize that it's a very potent therapeutic tool, and it can teach people and support people to have, you know, internal, emotional, spiritual, and psychological growth in a tremendously powerful and profound way. So I feel that that's quite a unique experience that I bring to the psychotherapy room, you know, to the consulting room and to my patients. So it's really that I think is quite unique, and I think does lend itself to the way in which I work. And the other thing I would say is that working in treatment centers with people who, if they go back out there and use again, are likely to die, you know, the chances are very high, and there are a lot of deaths of people who relapse in the addiction field, means that you learn to work quite quickly. So you learn to kind of not be directive, but be able to sort of move people along a bit in terms of the therapeutic work. Whereas I think there are lots of psychotherapists who are friends of mine who work in a really person-centered way, and that's fine. I don't disagree with that, but when they're working with especially addicts, what you find is the person stays very stuck and there isn't much movement, and they get very frustrated with it. And a lot of them come to me and say, look, I've got this person with an alcohol problem and they just won't stop drinking. What am I doing wrong? And what it generally is that they're being too person-centered in the way that they're working. There needs to be a balance. Obviously, we need to be client-led, and we need to we shouldn't make assumptions, but also we need to have some sort of understanding and analysis of the issue, and of how childhood trauma can affect people in, you know, as adults in the here and now.
Thank you. Okay, final question, Chula.
Yeah.
Do you feel your motivation to work with clients in this population has any bearing on your ability to connect with clients affected by childhood trauma?
What was the first bit of that question? Sorry.
Do you feel your motivation to work
Motivation
in this population has any bearing on your ability to connect with clients affected by childhood trauma?
Okay. I think my motivation initially was very personal, and came from my own experience of coming into recovery and being helped by some amazing therapists. And in fact, it was a therapist, psychoanalytic psychotherapist, named Simon Good, who got me into recovery. It was he that kind of guided me when I was still using heroin. I was seeing him as, and he said to me, look, I can't do the psychoanalytic psychotherapy with you because you're using drugs, but I could see you as a counselor. Would you like to do that? And I said yes. And then he introduced me to treatment, 12-step fellowship, and just gently kept dropping, planting the seed, as it were. And then that's really what caused the catalyst for me to get into my own recovery. And then came the motivation, wow, that's what I want to do. I want to be able to help people to, save their own life, basically, because I'm very aware that we can't save the client's life. They have to save their own life. And deal with the childhood trauma that might be under whatever it is that they're bringing to therapy, if that is the case. So I think, yeah, my motivation does, like, it informs the way I work, and it brings a passion to the work that means that also I believe that anyone can change at any age. I believe that anybody who does the work can get better. There may be a small percentage of people that have had such hideous trauma that they may need to be medicated, or they may never be able to face that pain. And there is a small percentage of people, and I would say maybe about 10%, but I would say 90% of people with childhood trauma, if they're given adequate help and support and the right guidance and time, to do the work on their childhood trauma, I strongly believe people can get better. Absolutely. And there's degrees of that. So, there's different people have to cope with different aspects of how their childhood trauma lingers into even that healing process. But I do believe that people can get better, and I never give up on anybody. I keep the professional boundaries, and I do my best not to be codependent and collude. But at the same time, I don't think anyone is a lost cause. I believe that we all should be given the chance to heal from our childhood trauma.
I really felt that, Chula, actually. I really felt that when you were talking about that. I could feel your passion. Is there anything you'd like to say before we end?
No, I think the main thing for me that I suppose that I struggle with in a current climate is that we live in this society where everybody's getting a quick fix. So the number of people that come into my consulting room and say, look, I've got this childhood trauma, I want to do some work on it because it's causing problems in my life. How many sessions do I need? Or how quickly can we do this? Or can I come and see you for 12 sessions? And people have this expectation that we can heal quickly, or that we can present a problem, be given a solution, apply the solution, and then suddenly, heal, a lifetime of difficulty. And that's impossible. It's impossible. And I think it's really important for people to understand that it takes time, and it takes a lot of different support mechanisms to be pulled into place for somebody to truly get better and to thrive. Because we don't just want to stop the pain, we want to stop all the things that are inhibiting the client's ability to thrive. We want people to love life and to feel joy and happiness, and build a fantastic life that they want to lead, rather than what their trauma is dictating. So I think it's really important for people to recognize, and I think it's clients and therapists, I think we all need to sort of acknowledge that a couple of trauma weekends isn't really going to do it. We need to be held through a process, and we need to give it the time that it needs. And that will be different for different people. I think that's vital.
Yeah, definitely. I completely agree. And it can't be measured, and there's no limit.
No.
Chula, thank you so much for your help with this.
Pleasure.